A very big hello to all my dear students. So, welcome to the T2O series of ophthalmology, favorite channel, you and I with. So, what next? Same series, Neetpg Are We Ready? Exams are on honor, and therefore, I'm going to take only 15 minutes, quick 15 minutes, rapid revision of the very important images that you should gain based on your previous exam. Okay, so let's start. We come to the first question. First image, I mean to say. And what do you see here? Very simple. There's a, what is happening here is laser assisted in this, right? So can you see this? This is topical anesthesia given. The flap is raised. How do you raise this corneal flap? It's with the flap surgery. We all know this. And how do we raise it? The flap can be raised either with a micro keratotomy or you can raise it with. You also know that sometimes we can use femto laser to raise the flap. If we take femto laser to raise the flap, then we call it I LASIK, Z LASIK, or Z LASIK. After this, you apply which laser are you applying to sculpt the cornea? You will answer this is your excimer laser. They've asked you the wavelength of excimer. Which excimer? It is argon, right? Wavelength 193 nanometer. Another question. Third question that is important here. After you have done this, okay, you should be very, very clear about the basics. Keratomyelitis is the changing curvature of the cornea. We have discussed so many times, more the curvature, more power is. If I'm correcting a myopia, I will flatten the center of the cornea. If I'm correcting hypermetropia, I will bulge the center. I hope this is clear. So, according to that, we do this laser sculpting, right? And once you have done the laser sculpting here, next is reshaping of the cornea has place. And now you put this flap back, you reposition the flap and the corneal curvature for if it is myopia, center of the cornea would be flattened, right? Another question. Next question they've asked you is what is the age limit? It should be more than the patient of yours should be more than 18 years for any refractive surgery. Okay. The next question is what should be the so when you are raising the flap and you've sculpted, you are left with some corneal stroma after the sculpting. That is called the stromal bed. So what should be the minimum stromal bed thickness that should be there so that this patient doesn't land up into the ectatic complication? Because if there is too much of thinning of the cornea, it can lead to ectasis. So you will say minimum stromal bed thickness that is required should be 270 micron. I hope you all remember what is the normal thickness of cornea. Normal thickness of cornea, what will you answer? Anything between 500 to 600, right? Okay, we come to the next thing. So, which is the second surgery here where that we have to also know where you don't raise a flap is smile procedure. Okay, a quick review here about the smile. What do you do in the smile? You are not raising a flap, directly focusing what? You're directly focusing the femtolase on the stroke. Cut a piece of it and then with a small incision, just take it up. What is happening with the small incision? Piece has lenticule has been cut and okay. What do you call this? This is what is called small incision lenticule form. Small incision lenticule. So very important. Lenticule extraction and not formation. E stands for lenticule extraction. Small incision lenticule. The smile procedure is, of course, the latest in the laser refractive surgery. It's a flapless surgery done with a femto laser. 2 points here. Femto laser, what is the pulse duration? It is 10 to the power of seconds. And the wavelength here will be 1054. Okay. And what is the other use of femto? We all know. Use it in femto laser assisted cataract surgery. Right. And we just saw that femto can be used to raise a flap in LASIK. Come to the next slide. Next is your Okay, so we have to revise the layers of the cornea. I think it's very simple. This is your epithelium. First question, what type of epithelium? It will be stratified, squamous, non-keratinized. Right? This is us, non-keratinized, stratified, squamous. So generally, if you report in the details of the epithelial layer, just revising with you, basal cells can be columnar, in between are the wing cells, and then comes. Okay, then we talk cuboidal. Then the shape becomes a cuboid. So there are three shapes in the same epithelial layer. Of that, if uppermost part, did you remember? Do you all remember microvilli, which helps to hold the tear on the corneal surface? Okay. Then we have Bowman's membrane, and after Bowman's is your stroma, then your Descemet's membrane and endothelium. So which is the layer which is missing? We all know there's a new layer here between the stroma and Descemet's, and what we call Dua's layer. Okay, Dua's is by the name of a late scientist Harminder Dua. Just remember, it's a layer between stroma and Descemet, and it is one of the strongest layer of the yeah, right? Okay. Any other question here? Yes. Which are the layers which do not regenerate? Do not regenerate. If they ask you, you should answer in this is a question. First answer will be endothelium. Second answer will be Bowman's. Please remember, Bowman's membrane is nothing but outermost part of the stroma only. So stroma and Bowman's will not, because that's the reason any damage. But yes, our first answer will be endothelium. Then Bowman's membrane. What regenerates? Epithelium regenerates, right? Epithelium will regenerate from where? From the limbal stem and some part of the Descemet's membrane. Okay. Come to the next important thing that is ours is physiology and what are the factors for maintaining the transport. Now I teach in a very, very simple way. Let's do that. We'll make a diagram here and learn it layer wise. Very quickly, I'll speak more verbally today. So very important, uppermost is your epithelium. So regular arrangement of epithelium. No mitotic clumping, no clumping of the epithelium. It helps in maintaining the transparency of the, right? Okay. Then second factor would be stroma. Regular arrangement of lamella in the stroma. The distance between the two lamella, if you have learned with me, is less than half the way. Now, how can you maintain that fixed distance? This is your exam question. Because of the glycosaminoglycans in the stroma, they've asked you which one. First answer is keratin sulfate, and second would be chondroitin sulfate. Okay? Keratin and chondroitin sulfate. This is what was recently asked. And of course, the very next important factor, of course, is the dehydration of the cornea, which is maintained by pump function and barrier function endothelial cell. Right? We all know that endothelial potassium ATPase pump. Because if you look at here, the cornea is all around surrounded by water. How is it dehydrated? Because this endothelium here not only is acting as a barrier, but it pumps out whatever water enters the, right? So this is the main mechanism to keep the cornea dehydrated. And dehydration of the cornea means the transparency. Correct? Okay. Any other factor? The vascularity of the cornea. Okay. Any other factor? Any other factor we can know is normal intraocular pressure. Why that is important? Because there is some basic stromal pressure of the cornea. And this stromal pressure in the cornea is around 53 to 5 mmHg. Okay. Now, when your intraocular pressure moves more than the stromal pressure, okay, so this stromal pressure, if the intraocular pressure becomes more, there is edema on that will lead to. Therefore, a normal IOP is very, very important. One of more factors has been absence of myelin sheath nerves, right? So, and a smooth tear film. That's also very important. Optically smooth tear film and absence of any myelin sheath. These are some important factors for maintaining the. Yeah, it's a very important topic. Whether okay. So once we know this, we come to the next. What are you looking at? Of course, these are true rosates. We can see the lumen in between and the cells. What are these known as? This recent exam question, we all know it is flexner winter state, right? So Flexner Winter is the arrangement of the cells, the treated retinoblast. Now, if there was no lumen, then what are they called? They are called spherurosates if it is no lumen. And then what is the name? We all know, we call it homerite. And what was the third differentiated? We would answer is fluorates. Quickly revise the pathology of the retina. The arrangement of different differentiated cells in retina. So, what is the next question in a retinoblastoma? Most common mode of presentation. We all know most common mode of presentation is leukocoria. Next question. Second most common mode of answer squint. Question. Most common mode of spread. Most common mode of spread. What will you answer? Through the optic nerve. You through the optic nerve. Next question. Most common non-ocular malignancy. Answer osteocyte. Please don't be in a impression that these are not answered. All the one line is very important. Then we talk about the next important question is about what is the gene involved in retinoblastoma. We all know it is RB gene. Where is it located? 13q. 13, long arm of 13, chromosome number 13, which is 14th band where you get the mutation, which is to red. And also very quickly, you please revise your classes aging as well as. Okay, so that was because it's a very quick discussion. I cannot go too much in detail. I can't take time here. Looking at here, this was another exam question of PG. It is giant papillary conjunctivitis. So when you say the giant papillary conjunctivitis, these are flat areas, right? These are some flat papilla, right? These are so this any GPC or giant papillary conjunctivitis is seen in, we all know, overwearing of contact. This was your exam. Okay, what is the similar picture that you see? We see that in case of vernal keratoconjunctivitis, it is also called spring catarrh. This is a misnomer because it mainly occurs in summer. Okay, so let's also revise vernal kerato. We all know these raised papilla in vernal are called cobblestone appearance. Another question is the same when you see the same picture on limbus. Now, what do you call it? These raised papilla has spots, and these are what are called Horner trunca. Just be familiar with the names, please. Just revise all this. Horner trunca spots and blood is correct. Anything else we would like to know? Since these are isnophils, next question. It's a type 1 hypersensitivity reaction. Then what is shield ulcer? It is erosions on the then some mucus deposit. Again, a feature of vernal kerato. And if you get a pseudomembrane over the cobblestone appearance, that is what is called Maxwell-Lewis sign. Any pseudomembrane over the cobblestone appearance is called Maxwell, right? Pseudomembrane over the raised papilla that is on the cobblestone. Of course, we treat it with anti-allergics and correct. And yes, any corneal involvement is also called. I hope you remember this. Cupid's bow. Right? We can Cupid's bow. So this was a very quick discussion and important. And yes, one more important point of vernal, which I said there is too much of rubbing child can lead to. This can be associated with keratoconus. Right? Can be associated with keratoconus. Okay. So what was the next thing they can ask you here is this was another question. Can you see what can you see in this light? There is some nebular corneal opacity, light reflection, but this is an opacity, and I can see here iron, right? So when you talk about iron found body, first question is most common mode. Why you get it? Answer: it is due to chisel and hammer. And since this is superficial on the cornea, if it is not too much of the depth, you can remove by a 26 pad and band, right? Okay. But if you go for an intraocular, whenever the iron becomes intraocular, what do you call that? Cirrhosis. right? A few very, very quick points here in siderosis. You should remember this, that in siderosis, first thing is they ask you what is the first sign. It's always lens deposit. Okay, then there is iris pigmentation, and finally it will be retinal. So this is when the retina is involved, what do you get is another question you should answer. Decreased B wave on electroretinography. Okay, when retina is involved, remember electro wave, this is B wave, small C wave, which is again A corresponds to rods and cones, that is photoreceptors, and B corresponds to bipolar cells. Right? So mainly bipolar. It's a decreased B wave in siderosis. Another question that I asked you is then how do you monitor it? So you say it is serial ERG. You can do serial ERG to monitor what damage the iron has already. Okay, right. Anything else that we can discuss around iron? If you remember, if your superficial deposits, please don't forget at the head of the region we call it Zucker's line. When it is around the trabeculotomy bleb, we call it Ferry's line. If it is just like this, you can see a deposit, not you know, it is idiopathic, no serious cause, and it is at the middle and lower one third of the cornea. This one is what is called Hudson-Stahley line, right? So we will remember Hudson-Stahley line. We will remember this occurs at the head of the pterygium. We will remember anything around the filtration is ferry. Are we missing into any other iron deposit? Flesher's ring. Don't forget, Flesher's ring is iron deposit, which is of keratinous. You call that? That is called, right? Okay. Talk about the next slide. This was the last slide. This is what you can see. The diagnosis. This was the exam question. It's a lid, part of the lid form. Now you all know that coloboma occurs when there is failure in the closure of the choroidal fissure. So when choroidal fissure is not closing, then that is causing. So just revise your embryonic development. What is the normal timing of closing of the fissure? Is 6th to 7th week of gestation. You have to know this. It is so you can get a lid coloboma, iris coloboma, lens coloboma, disc coloboma. Iris coloboma again very common. I think this was one of the questions. Most common site of an iris coloboma. You can answer in inferior. Right, all of you? So these were the quick discussion based. I didn't want to take too much time, but revise very quickly. All. Hope you enjoyed it. Thank you so much. Stay blessed and keep all the best. Just give your 100. If you're not anxious, you have your peace of mind, you can do it. That happens. You have to have a good sleep. You have a biological clock. Don't keep getting up and thinking it's only a cycle. Daytime. Want at least one day before the exam, you have to slow down and just to observe. It's not time to observe. It's time to see what I have seen. Please sleep on the day before the exam. Thank you so much.